this to the CTDSS YouTube channel, as we normally do for these. And I was going to ask Geisha, are you able to, let me make sure you can share, but are you planning on sharing slides?
Grace is going to be sharing for us this afternoon.
Perfect.
Yep. Dr. Rich, just let me know when you're ready. I can start sharing.
All right. I think we have a good group and it's 2:01. So I think we'll get started. And feel free to pull up slides, Grace, just make sure you're able to. You should have enabled screen sharing. And just want to welcome back everyone. I know it's been a little while since we've met, and appreciate you joining us. We're wanting to provide an update to the advisory council on kind of the status of the maternity bundle, where we are, and also discuss an item or two just to keep everyone in the loop. Yes, I'll provide the link to the YouTube channel. Give me one moment, I will do that for those who are interested. So, and Grace, I don't know if you want to go into, yeah, perfect. And feel free to go to the agenda. And for those interested, I'll paste the link here in the chat to the YouTube channel for those who are interested. So this is the agenda. We're going to talk a little bit at the program go live update, attribution, target price reconciliation, quality measures. I'll talk a bit. We'll have our Mercer team talk a bit. I think we can jump right in, because I think the program go live updates are probably the biggest one. And thanks, Carson, for saying if you could add your name and organization to the chat. If you haven't done so, that'd be great. Thank you. And so we are still working on getting the program ready to launch. Some of you are probably already aware, as we announced earlier this month, that we're having delayed the launch pending approval. But there's a few reasons for it, and our delay is we're saying it September 1, 2024, or with 3 months notice to providers, if we're able to launch earlier. And there's a couple factors that go into that. One is CMS approval. We had started some informal engagement with CMS. There were some issues in terms of just some reorganization and staffing changes that occurred on their end that led to a little bit of delay in some of that informal engagement with us. But subsequently, we've also identified a few issues with some of the work that we're doing in terms of policy development and making sure that all of the details are aligned. As many of you are aware, we've went through a few different actuarial support vendors, and we're working with Mercer through launch, and we'll continue to work with Mercer. Many of you may remember we had worked with Signify and then Optimus. And so there's just a few details in those the transition between our various teams that need to get looked at again and reworked. And we'll talk a little bit more about that later, but that obviously has a huge impact on and making sure we're able to launch successfully and on time. And we also want to make sure that anything we discuss, including things that come up today, we have time to bring to all of you as well as to providers who we know obviously need to know any of the details or anything that we're suggesting that we need to change to make this program work and run. So really our current priorities, you'll see here, that's the CMS SPA approval, the actuarial modeling, and then program readiness. And then we're continuing to do upcoming work on several things, including our provider bulletin policies and processes, program testing, dry run of the 2022 claims. That's to be able to provide providers an idea of how they would have performed historically, and then those performance with the performance report. And then we'll be holding an additional provider forum and forums next year as well. And then finalizing plans for dual integration policy. So just of note, we are, I think as many of you are aware, or most should be aware at this point, is planning on launching doulas both with a fee-for-service option, so doulas can get paid directly through via Medicaid and CHIP, as well as underneath the bundle where there's an additional payment to providers as part of that. So there's a kind of no wrong door approach to doulas, as we've previously discussed the importance of that. I know we previously were working with primary maternity care with Amy Romano and team, that they helped us with some of the early work on this, and we're continuing to launch. They're still waiting on DPH to finalize the doula certification so that we can move forward with our plans for thinking about how that doula benefit will be rolled out. Let me take a pause and see. I just provide a general programmatic update. We're going to get through some more details here in a minute, but I want to see if there's any questions, anything I said, or clarifications or follow-ups that anyone had. And if you can use the raise hand function, if that's okay, please. And I'll just say, if there's things that do come up, we're happy to take questions at the end as well. So if nothing as of yet, we can move on to the next slide, Grace, and I will, I think, turn it over to you.
Yep, thank you, Dr. Richards. So as we basically, I'll be covering some of the components of the maternity bundle payments as a program overall, and the calculation when it comes to reconciliation and all that good stuff. So first thing first is provider attribution. So the reason we want to have this section here is to clarify the situation. For the most part, during the whole 270 days prenatal, delivery, and postpartum, it's very likely that a member can change providers, change their OBs, from time to time. So when that happens, how do we actually attribute a maternity case to a provider? I'm sure that is a question a lot of people have. So we're trying to get into details there to talk about the provider attribution as the first section. So when it comes to provider or provider attribution, the first thing,
sorry, do you want me to just jump in context-wise? Because and just to say, I know, just as a reminder for those who may recall, last year we discussed provider attribution at length with a goal, I think, that we'd come up with, and many of you had, of trying to get as many people as part of the bundle as possible. And just as we had worked through some of the attribution at that time, as we've gotten to the kind of deep coding process for the attribution that then leads to the case rate setting and retrospective reconciliation, seen a drop in that we're working on trying to identify the reasons why, so we can hopefully maximize the number of people attributed. Sorry, I just wanted to give that little broader context. Grace, my apologies to interrupt you.
No. I think that's great context, Dr. Richards. So we will be filling in a lot more details later on when we sort out the logic. But as of right now, we're hoping to give a more high-level overview of the factors or the elements that we know that has been determined. So the first thing I want to talk about is the triggering claim. So what is a triggering claim? Triggering claim overall is a claim with a trigger code, a trigger diagnosis code. That is very broad and very brief. So we'll go into a little bit more details of what are the factors or what are the criteria that will be needed for a claim to be considered as a triggering claim. So those criteria includes, but not limited to, billing. It has to be a claim, a professional claim. Okay, the place of service on that claim cannot be urgent care, cannot be in the inpatient, ER, ambulance, or lab setting. So the urgent care, inpatient, ER, ambulance, or lab claims will not be considered as a triggering claim. Also, the claim shouldn't be a pharmacy claim. It shouldn't be a claim that indicates services happen in an independent lab, or any kind of durable medical equipment claim. So those claims are all overall excluded from when we flag a claim as a triggering claim or not. And obviously anything else out of those criteria, those claims have to have a trigger diagnosis code. So those are the triggering claims. So why does it matter? What is triggering claim? So those are the claims where we identify providers that they've been providing maternal care related services, right? So because the member could have a chronic disease, you can see their primary care provider for something unrelated to maternal care service. So we don't want to consider those claims to identify a member and associate a member a case with a certain provider. So that's why it's important to consider triggering claims. The second piece of it is trimester. So as we know, for the prospective case rate or case payments, anything happened during the first trimester is just going to be paid fee for service. Nothing will change. But starting from the second trimester and third trimester, when there's a triggering claim comes in, the provider will no longer be billed based on each individual claim. Instead, if there's a trigger claim comes in, they will start to get a sort of a case rate in the sense of like in the way of per member per month payments. So the fee for service claims will no longer be paid. You will get zero pay, but instead you will get a per member per month payments. So now we're going to talk about the second trimester attributed provider. So as I said earlier, a member can choose to go to different providers, along the way. So if during the second trimester, a member goes to a provider, let's call it provider A, for the first visit during the second trimester, then they move to a different provider, let's call it provider B, and then to a third provider, let's call it provider C. So those services, those triggering services could happen, by, in chain. And how do we associate that case with a provider is we're going to look at the last provider that provided a triggering claim or have a triggering claim during the member's second trimester services, then that case will be associated with the last provider. Okay. And then no matter if the member has been seeing 10 different providers during the second trimester prior to that, it doesn't matter. It will be associated with the last provider in the chain, and all of this claim costs that happen prior to that provider, that providing service, will be associated to that provider's case rate. So that's some key points we want to mention for the second trimester. Then we're going to talk about the third trimester. So if a member go to a different provider in the third trimester, the provider will be getting case rate. But if that's a different provider than the last provider in the second trimester, that whole case will not be included into the reconciliation, nor will it be included into the target price calculation. Basically, that case will be out of the maternity bundle pool, if you will. So, like I said, but that provider that happened during the third trimester will still get payments, but this whole case will be out of the target price or reconciliation calculation. But the cost that happened during the third trimester will still be linked to that last provider in the second trimester to consider their case rate, because we want to have this holistic look of the prenatal and postpartum care cost, and then calculate the case rate and associate that with a accountable provider. So that's what we're going to do as event happen, as provider changes during the second and third trimester. I just want to pause here to see if there's any question. Yep.
All right, go for it.
Thanks. So Grace, I just to get the nomenclature down, case rate isn't something that I've seen in previous presentations, and I may be mistaken about that. So is the case rate the episode target price, or is the case rate the prospective payment amount?
Case rate is prospective payment.
Okay.
Yep.
And and so I think you explained this, but I didn't entirely follow. So if there's let's just make it simple and say that licensed nurse midwife has been following a patient to the end of the second trimester, and then needs to go to an obstetrician who's a fetal medicine high-risk pregnancy individual for a number of visits. And let's say they co-manage the case and hand back to the licensed midwife, or let's say they don't co-manage and the high-risk obstetrician takes the lead at that point. Can you, and I know probably you answered that, but can you go through those scenarios and just talk about how the payment works or the case rates adjusted in those instances?
Sure. Sorry, I think I have, like I said earlier, the logic details is not finalized, but from my my latest knowledge about it, what happens is that we implemented some a criteria when we consider a trigger code actually happen. For instance, if in the case where a member goes to different provider in this third trimester, if it's a one-off situation, we won't consider it as a trigger event. So if that they only go it once, then it's not going to trigger this provider, the attributed provider change, first of all. Second of all, if it does happen continuously, we do, I don't know the details of whether that service will be considered in the trigger code list. If, let's say, if they do provide service that is in the trigger code list, then that going to different providers in the third trimester will trigger a provider change. However, that might, so this whole case will be out of the episode. So sorry, this whole episode will be out of the reconciliation or target price setting. But the providers that provide services during the third trimester will get case rate. So the new provider will be getting case rate in the third trimester. And then the initial provider have been providing service during the second trimester will stop getting payments. But if, let's say, they come back to their original provider in the second trimester, then the provider have been providing service during the third trimester will stop payment, will stop getting payments. And then the original provider will start getting payments again.
So, so I guess my concern is if there's a co-management arrangement, that is one practitioner remains the lead in the mind of the patient, but there's another obstetrician who's involved around high-risk aspects of the pregnancy and is doing visits, in a co-management capacity. It sounds like it could generate a lot of noise and even uncertainty about whether one is getting paid if you are the collaborating obstetrician in a high-risk practice, especially if the visits occurring in the same month. So the thing is, there's these demarcations around the case rate. You're paid on a monthly basis, but sometimes it's more fluid than that. You could see somebody in the first week of a month, but then see somebody else the third week of the month. And maybe it's for an important high-risk pregnancy related visit. There's an event in the second week. So how can we put practitioners at ease that the financial support for their doing what's right for the patient flexibly isn't going to be jeopardized by the new model?
I think it's a good question. I'll just say and I don't think Sandy, there's kind of a couple of pieces here. It's like, how do providers get paid the case rate, and just for background, in our conversations with CMS, just with how discussing it, kind of shifting it from a PMPM to a case rate terminology, but it's a perspective, it's still the same conceptual idea from what we had discussed over the last year and change. So just for some background as to why that term is being used, and you're like, where did that come from? So that's the rationale and reason really for case rate, that term, but it's the same thing we've been discussing for an extended period of time. I will say, I think one of the things that we're still looking at is figuring out how frequently there's true switching happening, because and there's switching that, like you said, there may be some co-management versus actual switching, and we want providers to get reimbursed and paid, and they make sure. And so I don't think Sandy, so the case rate logic with how that gets triggered in the system versus how we're doing the reconciliation, those things will be different to partially just because, if someone goes and sees and leaves a bill, it goes to our MMIS system, and that has to be able to pay out to providers very quickly. And so we're trying to make sure we err on the side of paying providers as than not. So maybe that's something we can bring back in a follow-up, just as an example, Mark, to make sure it's clear. Is like, what happens if in this situation? This is a little bit attribution as it applies to the retrospective reconciliation, as opposed to necessarily just the case rate, which I think is what the case rate and the payments that are happening in the moment. So say the OBGYN, there's a certified nurse's wife that they go see a maternal and fetal medicine, wanting to make sure that those providers are getting paid for those services. So I think we can bring that back as an example of what that would look like. Attribution as it pertains to the retrospective reconciliation ends up, again, that applies to shared savings. This is where we're trying to work through some of the challenges that we were seeing, as Mercer or as Grace can elaborate, where we saw in this data a lot more switching than we had when we ran the numbers last year. So, which is part of the reason we're kind of going back to just to make sure that we have this logic very tight, because if there is people going back and forth and they're switching, how do we make sure that we want most of our members attributed to providers, right? I think that was a goal that we had talked about early last year and really worked to refine that. And as we've gone through this process and the Mercer team has kind of refined, it was like, oh, it looks like there is actually a lot of potential switching. So we're trying to work through where are the issues and how can we refine that. So I think we'll have to come back on kind of both of these pieces. One is like that switching piece and kind of elaborate what happens when you're saying, like, obviously what happens within 1 month period, right? If someone sees the certified nurse midwife on the first week of the month and the second or third week they see the MFM, what's happening? And so we can bring that back to you as maybe an example in our follow-up. I know we haven't met for a while. I anticipate we'll be meeting again in the coming a little bit more frequently as we kind of iron out some of these details.
So if I could just make 2 follow-on remarks, Amy, if you don't mind, before just to continue the thread. So my understanding from conversations with practitioners is it's the case rate and the standard sort of doing the work of prenatal care, labor and delivery, and postpartum that is at the core of folks' concerns about whether their practice is going to continue to and the new model is going to enable a continuity of revenue sufficient to support the core business of providing care. The reconciliation attribution for performance measurement and accountability purposes, I would say, is a substantially more distant concern. And so while it's super important from a technical perspective to understand ultimately how that happens, I think when my sense is when practitioners have raised it to me, they're really fundamentally worried about having the flexibility to provide care in the way they traditionally have and as best they're able without somehow the new payment model around prospective payment or case rates jeopardizing that. So that's so in the explanation, I think to focus squarely on the revenue associated with case rate, I think it'll be more productive. The other is that the nuances that you and Grace have acknowledged are so important to delineate technically. And while your slides do a very good job, I think there was at one point a commitment to providing a technical guidance document, a complete compendium of what I would propose be draft technical specifications before a provider bulletin is issued, because provider bulletins then have the look and feel of policy and kind of our policy. And so we would just strongly encourage the department to publish a complete technical summary of the methodology, all aspects, and make sure that there's at a minimum clear understanding, ideally support for what goes into the final regulation or provider bulletin.
Thanks, Mark. Amy?
Thank you, Mark. That was a really important question that probably many of us have. And thank you for the response, Dr. Richards. I have another layer to add to that. One is, I think are you going to be looking at the difference between shared care and transfer of care? And also when there's shared care, if someone maybe sees another practice due to high risk at the very end of the pregnancy for like the last few weeks, and they return back to a person who does the triggering code in the second trimester for postpartum care. Have you thought about how you would calculate that too when they return to that triggering provider's second trimester code and they're returning for postpartum care?
Yes. sorry, Dr. Richards, do you want to speak first?
Well, and I think, Amy, you might be are you wondering mostly about how, in terms of case rate, or talking about the retrospective reconciliation, the shared savings component? I'm assuming the case rate portion.
The case rate, meaning the bundled rate? Yes,
But yeah, the monthly payments, essentially.
yes.
Yeah, I think this is kind of what I was just saying with Mark. It'll be helpful. We'll have to, this is where the obviously the attribution competes of like who's getting that rate, the case rate, also known as what we've called previously, I think, the prospective payment. How there's again similarities and overlap between that and attribution for retrospective reconciliation, but there are some differences as we're working through this. So I think this is where we need to bring back some examples and talk through them, because there are complexities to how those payments will go out. And I think giving you some examples would be helpful.
And I think I'm looking forward to how we learn more from this as we look at the rate of transfers or moving back and forth between two providers, and how we're going to handle this is going to be very interesting to learn.
Yeah. And go ahead, Grace.
Sorry, I just want to add a little point here. Preliminarily, again, like we're still in discussion on finalizing the logic, but preliminarily, what has been considered into the case rate is the full prenatal and postpartum care. So, Amy, in your example, if they're seeking some special care towards the end of third trimester, let's say, the cost that happened, or that cost that the last provider provided services for, those costs will be included in our case rate calculation, and that will be attributed to the OB provider that has been providing services in the second trimester. So those costs will not be forgotten, and it will be included in our case rate.
Thank you, Grace. You're very clear. I appreciate your explanation.
No problem. Thank you. Thank you for the question.
So I think we'll obviously need to bring back some case rate components as well to this, and also obviously the finalized attribution logic for shared savings, the retrospective reconciliation as well. I know we have, we just wanted to at least highlight that we've kind of gone back and had to relook at this, just given some of from some of the logic as we were trying to run it, that we did see a lot more switches than we initially had when we first had looked at it last, I think about February or so. And we brought that to many of you may recall that. So that remains really important to try to attribute as many folks as we can. Obviously, agreeing that I think, Mark, as you alluded to, and Amy, your question, making sure that providers that are providing services are getting reimbursed for those services as well. So you definitely will hear more to come. And I think, Mark, we definitely are interested in trying to get out as much technical documents as we can, as well as potentially just publishing those on our website when we are able to, so that people can review them and see them. Maybe we'll keep going, Grace?
Sure. Yes, sounds good. So the next component I would like to talk about today is the target price, right? So the target price, we're talking about case rate, aka the prospective payment. So that is paid on a monthly basis, and that is preset before the performance year starts. Now we're going to talk about another component we'll also preset, but recalculate towards the end of, after the end of each of the performance years. So that is target price. So target price includes all of the, prenatal, delivery, and postpartum care, versus the prospective case rate should only covers the prenatal and postpartum cost. So just want to note that. So the target price does include like the first trimester, second trimester, third trimester delivery cost, and then the 90 days postpartum cost. So all of it. All right. That's pretty much what we're looking at here. We have a list of the services that will be included in the target price calculation. So that includes all the, maternal care related professional services cost, lab diagnostic, imaging cost, screening cost, pharmacy costs that related to maternity care. There's also the birth center or the hospital costs related to maternity care as well. We're also going to include the doula and then breastfeeding support cost, and also some of the prenatal group visits, child education, care coordination activity. So all those costs will be bundled into this target price. So there's a table on the right, sort of summarize things for the time frame of cost that will be included in the target price. I just want to note, when the program first launched, the newborn care will not be part of the target price. Right, I will move on. So the target price will have certain cases excluded from all the claim costs that we'll consider as target price. So when a member is under 12 years old or over 55, that member will not be part of the target price pool. If a mother leaves the hospital against medical advice prior to discharge, that case will also be excluded from the bundle. From the target price or reconciliation. There's also a situation where a member have a substantial gap in enrollment or eligibility. That case will also be out of the reconciliation. But there will also be cases where providers will get the case rate, the prospective payments, but they will not be considered as part of the bundle, part of the reconciliation or the target price. And those include pregnancy where there is actually no claims for the first 2 trimesters, which means that the member happened to either not eligible or did not seek any care during the first or second trimester. This case will be excluded from the reconciliation. Also, if a delivery does not happen to have a facility claim, so we can consider that orphan episode. So these episodes will be also excluded from the target price or the reconciliation because it's going to skew, the results, the price quite a bit. Also, when the newborn baby is the baby is stillborn or the baby was born with serious congenital anomaly. This case will be out, and then if the baby could not be linked with any delivery episode, all these cases will be out of the reconciliation. I want to pause here to see if there's any questions.
Just going to flag these should look very familiar from what had been seen earlier this year. Just revisiting it or make sure kind of as a refresher.
Thank you. I'll move on then. So here is a chart where sort of lay out the workflow of how the target price by provider is calculated. So first thing first, we're gonna use 1 year prior, aka historical claims, to come up with the historical price. But it's not as easy as just summarize all the claim and then calculate a episode or a case cost. Instead, there are steps that we're going to take to standardize and normalize some of those episode costs. So the first step we'll take is called standardization. So what we're going to do is that for some of the inpatient and some specialty services, we're going to look at a statewide average cost by diagnostic group and severity level. So we're going to calculate a statewide rate for each of the diagnosis related group and severity level, and then apply that standardized cost to each of the episodes or each of the inpatient claims or specialty claims to come up with a standardized episode cost. And that will differentiate by provider TIN. So each provider TIN will have a standardized episode cost. Okay. And then we're going to Winsorize. So we're going to look at each of the episode, and then we're going to look at the 5th and 99th percentile. Any episode cost that's lower than the 5th percentile will be cropped at the 5th percentile, and any episode that's over the 99th percentile will be capped at 99th percentile cost. So we sort of want to throw out the outliers and then sort of normalize their cost. Then we're going to do the trending. So because all the historical price is based on the claim experience 1 year prior to the performance year, we do want to consider, or we do want to factor in the trend component. So the trend we'll be using institutional knowledge from the department to trend the historical price 1 year forward to the performance year. So that's the steps we're going to take to come up with the historical price. We also do understand that among providers, the member profile, acuity profile, and then the general area, there's area factors to the member profile as well. Those will all be impacting, the member risk pool, as well as, the members' medical needs. So we will be considering both the health risk factors as well as the area deprivation index, combine those two together to come up with the risk adjustment factor to normalize the historical price. And that will be considered as a risk adjusted historical price. And that's 50% of what we're going to use as what we're going to consider as the final base price. So this 50% of the provider-specific risk-adjusted historical price will be combined with a statewide historical price, and that will be considered 50% of the blend. So these two will be combined into a base price, and that is, again, on the provider level. Then we're going to multiply that base price for each provider with their actual performance year risk factors. Again, this performance year risk factor will be using the actual, the health risk score as well as the ADIs together to come up with this performance year risk factor. And these will be multiplied with the base price to come up with the actual performance year target price, which will differ among providers. So that's kind of the workflow we're going to use to come up with this target price. Any questions here? Hey, Mark, see your hand raised.
Yes, Grace. Can you say a bit more about, I understand historically the department has identified the importance of adjusting for differences in the unit cost of the hospital in which the delivery occurs. And I assume that's what the asterisk refers to the standardization.
Yes.
Can you explain what those words mean in terms of the methodology? Because I think I have a question about that methodology, but I want to make sure I understand it first.
Yes, absolutely. So what we're going to do is that we're going to look at the institutional claims and then sort of summarize them statewide and summarize them by the diagnosis related grouper, and then each severity level. Let's say if diagnosed, I'm just going to use, just as an example, group A and then severity level 1. We're going to look at all of the claims that have the same diagnosis code and then the severity level, and then come up with the average price. And then that average price, the statewide average price, will be applied to each of the episode, so that, for instance, if a claim happened in hospital 1 is originally $1,000, but then the standardized price is $800. We're going to use that $800 to replace that $1,000 that was originally on the claim, so that we come up with this theoretical hospital cost, and then including that with the rest of the professional services cost to come up with episode cost.
I understand that better now. Thanks, Grace.
Yeah, no problem.
And Mark, I assume you were just wondering about the pricing variation to make sure that was accounted for. Is that?
Yeah, well, I knew that's what I was. Yes, I have been thinking about methods for price standardizing, and I see now that the standardization is across providers statewide. So it just wasn't clear to me, but yes, that's what I was looking for, and it is reassuring, because at least on the face of it, it looks like it would effectively achieve the neutralization, if you will, of the price differences between hospitals, which I assume reflects also the cost of things like GME and that sort of thing that are added. So there's a component in the pricing that is a GME component that varies. There's a wage index component that varies. And if you're actually looking at, for a DRG price and severity, a DRG group and severity level, what was actually paid on the claim, I think that will work because it will reflect the results of the application of GME and wage index factors. That's what I'm thinking.
Grace, I'll defer to you if you think that sounds right. But
Yes, that sounds right.
Okay, thank you.
Problem. Right. If no other question, I will move on to the reconciliation. Okay, so as I said, the purpose of setting up a target price is ultimately to compare it to use it as a benchmark to compare to the actual cost experience. So if the target price for an episode for provider A is $20,000, and in reality their cost is $18,000. So that means that indicated that they've been more cost efficient, so that they will be awarded potentially with a $2,000 of savings. So that's kind of the concept here in general. So a couple of things we want to note is that the reconciliation will happen no later than 6 months after the performance period ends. We'll have a slide of talking about timeline later, but that's just general. The idea we'll kind of do this reconciliation on a very timely basis, and that's the goal. And also basically the bundles will be reconciled once per year as of right now. That's the plan. But we will be providing a quarterly provider data reports just to see where the target price comparing to the actual cost being looking like. So, it will hopefully help the providers to track their experience over time. And then for year one, we also want to note that whenever we talk about a comparison, there's upward and downward risk. So for year one, the providers will not be responsible for any losses, which means that if your actual cost is higher than the target price, you will not need to pay anything back for year one. Instead, if there's, if is the opposite way, if the actual cost is lower, you will potentially be awarded with the savings. So also, we just want to note on bottom here, the actual cost will be including anything they have been paid based on the claims, including like the services happening in the first trimester or the hospital service costs. All of those will be included, as well as the prospective case payment that has been paid on the PMPM basis. So all those will be part of the actual cost as to what can be compared against target price. Okay. I will pause here to see if there's any questions. All right, hearing none, I will move on to the next slide. So as I mentioned, we just wanted to provide this timeline illustrating how the process will look like, assuming that the go live day will be July 1st, 2024. We understand that as of right now, the go live day might likely be September 1st, 2024. If that's the case, all the starting day and end day will just shift 3 months forward. So let's say if the go live day is July 1st, 2024, the performance year one obviously will be July 1st, 2024 to June 30th of 2023. Prior to the go live date, so we'll use the experience of calendar year 2023 to preset or have a list of accountable provider. We'll also preset the prospective case rates and then the target price. So the target price we'll use for our quarterly reporting during performance year one. The prospective case rate will be set so that providers will be able to get paid when a trigger code comes in. Obviously, the accountable provider list will give us an idea of who will meet the 30 episode threshold, so that they will be, participating into this program. So these elements will be set pre-go live date, and will likely be used this 1 year of calendar year 23 experience with 3 months of run out of claims to come up with those calculations. And then after the performance year 1, 3 months after, meaning starting October 1st, 2025, we will take this 1 year of performance, 1 year claim experience, and then we will redefine the final accountable providers, because the list that we set prior to performance year 1 use historical experience, which might differ with the actual experience in performance year 1. So we'll take the performance year 1 experience and recalculate, redefine the final accountable providers, recalculate the target price, and then obviously come up with the final share saving amount. So all that will happen during the October 1st, 2025 to December 31st, 2025 timeframe. And at that time, we'll have the claim experience with 3 months run out. So this is an overview of timeline of what will happen. If there's any question about it, I'm happy to take any right now. Hearing none, I will move on to the quality measures. So, Dr. Richards, I will give it to you so you can talk about MAE.
Great. So wanted to discuss with this group the maternal adverse events measure. I'll just say this is the measure that we had discussed earlier and gotten some feedback on. This is a measure that you'll see the measure description there, that calculates the proportion of deliveries of greater than 20 weeks gestation with any of 21 maternal morbidities plus maternal mortality occurring during the hospitalization. And we're using it for claims with risk adjustment, uses 30 risk variables. This was a measure that was modified. As you may recall, Yale Core had been helping us with measure development and selection. They had developed a measure, Yale Core had developed a measure for CMS that will be publicly reported by hospitals using claims data starting in 2024. And we had asked them to modify that measure to work for claims and that we could use for outpatient providers. We've gotten a lot of feedback on this measure. And I'll just summarize that. You'll see some of the bullets here, that there's some concern based on the measures created for measuring the quality of hospital labor and delivery services. So it's really focused on hospital quality, not necessarily outpatient provider. It focuses on conditions that are heavily influenced by hospital clinical care. It's not developed for the purpose of assessing quality of care delivered by community OB practices. That's a summary. That's our summary of what we've heard. If there's any providers that want to add additional context, we'll feel free to add that here. And then some of the considerations that we've had in evaluating the measure subsequently. So we took that feedback very seriously, and we thought about it, as well as some of the commentary that's come out of this group before, and acknowledging that there's a disproportionate impact of maternal adverse events that have on birthing people of color. I think that's extremely important. That's at the heart of kind of how we've tried to think about structuring this maternity bundled program. The importance and support of the advisory group is placed on this goal in the past of really trying to reduce those adverse events, especially for birthing people of color. And that Yale Core, who has a lot of expertise in develop this measure, helped modify it for us, for DSS, in assisting with this implementation. And the measure is risk adjusted and actually accounts for small number variation at the provider level, which we think is really important, especially for providers that don't have a lot of births. And so our recommendation that we'd like to discuss with this group is some changes to how we want to implement it, especially in year 1. So we're recommending that we, and as of now, plan on changing the impact of the measure from an 18% portion of the pay for performance total to 6% in the first year, with the aim of further validating that measure, and then in the future increasing the importance of the measure after pending further measure refinement. And so, this is a significant change to the quality program. Again, we definitely want to say we're hearing the concerns that the providers have been raising. but also acknowledge that we think this is a really important measure, and there's not another good analogous measure to be used, which is how we landed on this previously. So I want to pause, take feedback from this group, and see if there's any other considerations that DSS should be taking under that pertains to the maternal adverse events, and how we're planning on implementing it. Mark, please go ahead.
Dr. Richards, so I guess just to, in the interest of full disclosure, the obstetricians affiliated with hospitals, many of them have reviewed and weighed in on this, and concerns we didn't express earlier in the process are reflected here, I think, in an accurate way. And we appreciate the department's proposal to make an adjustment to accommodate the concerns. It's our belief that it's critically important because of the optic. People will see this measure as reflecting something about obstetrical practices in the state, for which this measure is reported publicly, and because it hasn't been validated as a measure that is where variation in performance is it's not a valid, it's not been developed or established as a valid measure of practice performance, and performance isn't impactable based on what a practice does. Our concerns about that lead us to suggest that it instead be implemented as reporting only, and that time and effort be dedicated to adjusting the measure for the purpose for which it's intended, and then going through a validation process before it's actually incorporated into the program in a way that's tied to financial rewards and quality assessments. So thanks.
Thanks, Mark. Appreciate that perspective, and appreciate the input you've had on this. Any other input from anyone else? Well, if not, and Evan wants to share any subsequently, we definitely would welcome hearing them. And we'll take that back again. Mark, and we'll consider this. We'll make sure to bring this to the next group or wherever we've finalized. And if we've heard any other feedback, we'll make sure to report that out. Grace, I think I'm passing it over to you because obviously I'll just note if we're reducing the maternal adverse events, we would be increasing other measures to get to 100%. And so we have done that, and you'll see we've increased the pay for performance total measures. I'll note the C-section rate increasing, and the focus on postpartum care as well, each getting a 6% bump from what they were previously. Grace, I'll pass it over to you.
Thank you, Dr. Richard. That's exactly right. So on this slide, we'll see the 10 different measures, 5 of which are pay for performance, and then the second, the bottom 5 will be pay for reporting. And then, as Dr. Richards was mentioning, we did increase the weight for C-section births and postpartum care, and then the prenatal care and low birth weight remain to be 12%. And then, as you can tell, this 10 measures will add up to 100%. So that's what we're going to be used as the weighing to come up with the final performance score. So I will go on to the next slide. All right, so here is a flow chart of how the final the scoring or share saving calculation percentage will be calculated. So there are two factors, two scores. One is the performance tier score, and one is the improvement tier score. So the performance tier score is basically to comparing each of the quality measures current raw results to the min and max of the whole group's performance in the prior year. So we're going to calculate for each of the measure, each provider's score, raw score, comparing to what has been last year or prior year's min and max. So by calculating that percentile for each of the measure, we're going to use that weight that we're talking about in the prior slide to combine them into one performance tier score. So again, this performance tier score will be developed using all 10 of the quality measures. And I do want to note for the reporting measures, the 5 that we were seeing in the prior slide on the bottom, we're not going to use their actual score. We're going to use 1 to indicate they did report. Sorry, did someone want to jump in? Okay, so for the 5 pay for reporting measures, we're going to use 1 to indicate that they did report, 0 to indicate they didn't, and then if any of the providers did provide reporting for those measures, they will get that 6% for each of the measure. Okay, so it's not going to be based on the raw score; it's going to be based on whether they report it or not for the bottom 5. So that way we combine the 10 measures overall score into one performance score, and that performance score will range from 50% to 100%. And then the detail of the criteria will be shown in the next slide. But I also do want to talk about the improvement tier calculation. So what this is to compare each provider's performance during the performance year with their prior year's performance. So this is sort of like a comparison to see if they've been improving for each of the measure over years. Okay, and then for the improvement tier calculation, we'll only be considering, or we'll only use the pay for performance measures. So that will be the 5 measures on the top, and then we'll combine them, reweight them, and then come up with the final improvement score, for the year over year comparison. And then when we get this two score, performance score and improvement score, we're going to compare them. And then the final score will be the max of these two. So in this example on the screen, performance score is 90%, improvement score is 80. The final score for that provider will be 90%, which means they will get 90% of that net savings that we were showing in the prior, in the reconciliation step. Okay. I will move on to the next slide. All right, so in this slide, we kind of lay out the detailed calculation steps, how we normalize each of the metrics, each of the measures raw score comparing to min and max of the prior year. How do we inverse it if it's, if a lower, to ensure that a higher score means a better performance. And then also for how do we make sure the measures, each of the measures results is between 0% and 100%. Because, in a case where somebody's performance is way above the best performance during the last year, they will not get 200%. They will be capped at 100 versus if somebody's really outlying, not performing that well compared to last year, below even the lowest of the peer of last year, they will get 0 instead of a negative score. So we'll do that cap to make sure the scores for each measures is between 0% and 100%. So then we were going to weight them all together. So these, I won't go into too much details here. It's basically outline of the steps we're going to take. And then the interesting, we do want to share is the 2 tables on the right side where we have those different performance criteria and what the corresponding tier will be, and then the percentage of share saving they will get based on their performance. And you can probably tell this is slightly different than what was initially shared in prior discussion, but we just want to ensure the design of the tiers can differentiate providers' performance. So overall, there will be providers getting 50%. There will be provider getting 100%. So they will be rewarded accordingly based on their performance. I will pause to take any questions. Hearing none, we will be, so in this slide, we did actually take the 2022 experience to, and also obviously 2021 as that's the comparison as the prior year. So we did look at historical experience and calculate the results among the provider groups. Obviously, this is a sort of a distribution chart so that we know where the providers spend as aggregately. So as we can see here for the performance tier score, there are 13% of providers got 50%, and then there's also 9% of the providers got 100%. Got 100. Sorry, my screen is 6% of the providers got 100%. And then for the improvement tier score, it ranges from 50% to 90%. So obviously nobody got 100%, but there's 30% of providers actually got 90%, which is the best result they can achieve for the improvement tier score, which is wonderful. And then for the final score, as the goal goes, we want to see a distribution ranging from 50% to 100% to identify providers' performance differences, and we did achieve the goal because 6% of the providers got 100%, meaning they will get every bit of their net savings, during the reconciliation step. And then 9% of the providers will get 50% of the savings due to their score being 50%. So that's just an indication of what we've been seeing from the 2022 and 2021 experience. Obviously, for performance during performance year, this distribution might change, but here's what we've seen with the experience we have. I want to pause to see if there's any questions.
I'll just know we're still just finalizing this slightly, these numbers, but we've adjusted. So if you may not recall that this was a little bit different than what we looked at before, but we didn't have the data to kind of help set the parameters. And so now we're adjusting it to try to create distribution. Go ahead, Mark.
So my question is about the 100% share, which is if you get top perform, what percent of the shared earnings is potentially can potentially be obtained? So if you, based on performance against the price benchmark, generate 20,000, are you potentially you can earn 20,000, or you can earn only a share of the 20,000?
Yeah, 50%. We said for a share total of shared savings. So out of 100, so if there's a potential shared savings of, I think Grace, your example was 20,000 for target price, 18,000 actual cost. The net is 2,000. That would be 50% of that would be available. So 1,000. Whose example? Grace, does that sound right? Feel free to modify that if you want at all.
Yeah, Dr. Richards, I think I might need to go back to take a look to finalize, but that sounds right.
With our request and comments, obviously, given that there's not really much in the way of new money for practices to beyond what's provided for doulas to drive improvement, that there's in a true bundled payment program, capitated program, you get 100% of the savings. So that was obviously what we advocated for, but just clarity as to what it is helpful. Thanks.
Paul, I think your hand's up.
Hi, how are you? I heard you say that you have run these numbers for the prior year or the prior years. I feel it's really important as a provider group that we see what our prior data looks like. We really need to have some transparency to understand where we would be in those performance tiers in order to assess if, proceeding with this makes sense for us, because again, I echo some of Mark's statements, but it's really important for us to understand where we are and how hard we're going to have to work, or what does this mean? We've been in the bundle episode space for many, many a year. I think we probably, as an OB/GYN group, have had most experience in this. And so we know the pitfalls and we know the challenges. And sometimes we compete against ourselves for performance improvement as opposed to competing against the group. So we really need to see our data to really understand what this model translates to us, and helps us reconcile, to our constituents that this is something we want to proceed with.
Yeah, Paula, makes sense. And I'll just say we are still, and I'll just first just say, we're sorry we don't have this to you at your fingertips. We were anticipating we would at this point in time, but due to some of the, as you can imagine, the attribution becomes an extremely important foundational component of calculating case rates, as well as not so much so for the quality measures, but more so for the dollars. And so we really have had to go back to make sure that we have that nailed down before we can provide you the information that I think you need. And so I just want to say sorry on behalf of DSO that you don't have that. And we understand the importance of you having that information to help you feel informed about where you fit within this model and how it will affect your practices.
Yeah, I just want to add, Paula, if you're talking specifically about the share saving percentage, like the quality measure scoring, let's just say last year, prior year, you've been done fantastic and you're the 100%, you're the best performer. And then this year, meaning performance year, you remain to be the best performer among your peers. In that case, even if, I'm just hypothetically speaking, even if you're done. So what I'm trying to say is coming up with the criteria to show that why, you don't necessarily have to compete with yourself to be the, to get the 100%. I don't have it in my mind, but we can take that back and think of an example to show you, to indicate that concern.
Thank you.
Yep.
And just echoing that, I think that's in terms of trying to construct this model is really to have both a performance tier and an improvement tier, so that there's those who are already high performing and you remain high performing, even if you went from 95th percentile to 92nd, you can still remain in this potentially very high tier, even if there's a drop. So that's just that's not an exact example, but that's generally how we've thought about constructing it, so that those who are already performing well can obtain 100% and then can continue to, if they remain high performing. So they don't have to feel like they're competing against themselves, they're just remaining a really high performing practice.
All right, thanks, Brad.
And definitely we can bring, hopefully the examples, I think will be, like you said, I know it's much harder to hear theoretically or what we're talking about. When you see your numbers, it'll make it much easier, I think, understandably.
Yeah, I think we definitely need that concrete piece of this to really understand how the model flows.
Yeah,
I think
definitely, Antonia, I was just going to say, and I'm sure if I'm sitting in your shoes, I don't mean to speak for you, I would say, like, I think anyone who's a provider has been asking for that. And we, I'm sure, I would imagine I would be frustrated not having it at this time, despite wanting it. And so I just want to acknowledge that and say we are committed to giving you that information. Understanding it is really important.
Thanks.
So if hearing no other question, I think that concludes our presentation today. I will hand it up. Mark, I see you off mute.
Yes, I had a trailing comment, but I didn't want to get in the way with where you were headed. So I did take myself off mute. So, because it was less technical, and it's more just about, I guess there's a technical element, but if you don't mind, Dr. Richardson, Grace, if I can walk back to the beginning of the presentation where you talked about the case rates. The case rates describe a methodology for establishing the case rates. And that is, or I guess this is the attribution that's the basis for conferring the base rates. The concern that that our members have expressed is about, I mean, fundamentally, we're not sure why there needs to be a case rate, and that because it's because the case rate it's creating complexity, but it doesn't seem like it's actually, and it's also creating some risk around revenue, and it doesn't seem as though there's much that benefits the provider from a flexibility perspective, especially because many, if not most, providers get a global payment retrospectively. And so I guess our request, and I'd welcome observations in terms of how this can benefit clinical practice, because we do believe practitioners are going to have to do the number of in-person visits they did under the global, but it's hard to provide better care with fewer visits, we think. And so our concern is about this complexity jeopardizing the revenue necessary to run a practice and the adequacy of the rate over time. So one of the concerns is about the incentives at play and how they drive changes in utilization patterns. That is, that some practices may shed higher risk patients that were the basis for the calculation of the case rate in a base year, and other practices may accept those patients, because I think there are some practices that work for our members that are doing everything they can to support the higher risk service needs of Medicaid beneficiaries. And so they might have a rate that's based on a different patient mix and resource intensity. And as those events occur in a year or from year to year, the case rate could be at odds with the resource demands for the practices that end up with higher risk patients. That was a really long-winded way of explaining what's probably a simple concept, but that, I guess I'm wondering if you have thoughts about that issue as to whether some practices may end up with more sicker patients with more resource demands for which there isn't enough revenue to serve them well.
Yeah, I think it's a great Mark Gunder's question in terms of, has to do also a little bit with the reconciliation, I think, to the case rate. And just to say, those are some of the details I think we're still going to be finalizing. It is things that came up in our informal conversation as well with CMS. And I think appreciate your concerns, with providers potentially feeling like they're having to take on more complex cases in coming years. I think those may be outlier examples, but it's obviously important that we have an understanding of what the impact could be and how are there any ways that we can mitigate that. So I think something we can take back and we'll discuss. Grace, anything else you want to add to that?
Yeah, I'm just gonna answer it from a very technical perspective, this is what I'm bringing to the table. But basically, the risk profile differences between prior year and then the performance year is definitely accounted during the reconciliation. So in the example that, sure, the case rate, because we were using historical experience to come up with case rate, it won't necessarily reflect the actual risk profile of members during the performance year. That is true. But during reconciliation process, if the provider actually happens to take on sicker patient in the performance year, their target price is going to be adjusted accordingly. So maybe that provider won't get as high of a case rate ongoing, but during the reconciliation, they will be compensated for that. So they will have a bigger net saving pool so that eventually they might get, a higher saving awarded to them.
So the operative word there is might. There are a lot of, so this is, Grace, a perfect example as to whether is how the reimbursement around the shared savings opportunity is not the same as ensuring that you get paid sufficiently well to support the management of the patients you have at your doorstep. And the speculation on a savings opportunity is not the kind of assurance providers have had historically, whereas if they have sicker patients coming through the door, the payments they bill for on a fee-for-service basis, that's reflected in there. I can't emphasize enough the importance of not thinking that the shared savings methodology is a substitute for ensuring the adequacy of revenue, even especially for providers who, despite their best efforts, have a not great performance year. Based on the data you've presented, providers are in a best case will get 50% of shared savings. So if there's $20,000 savings, they'll get $10,000. But that's a whole spectrum of savings opportunity. That 50% is going to be substantially less for most. What that means is that $1 less you spend or get paid for resources you expended get, as you noted, factored in as a savings, if you will, in the target price. But you at best get 50 cents of that savings back, and more likely it's going to be 30 or 25 cents in the dollar. So you will not be made whole. I think it's essential that the department look at a methodology for ensuring that as the characteristics of the patient population that a practice serves change over time or within the performance year, that there is security around having revenue sufficiency to provide the day-to-day care needs of their patients, regardless of what the shared savings opportunity is, which is supposed to be a bonus, not compensation for the everyday work of serving patients.
Yeah, and I think, Mark, we'll take that back and talk about it. And I think, again, just to note, like that case would have to be a significant shift in your case mix, which I understand is a concern and a real one, and something we'll definitely consider, but just acknowledging that that would require a pretty significant shift in the population of someone serving, which is possible, but obviously something that we'll discuss.
I understand, Dr. Richards, and I'm just doing my best to convey what I'm hearing from the boots on the ground. So thanks for considering.
Thank you. I think, and Grace, I think that's all we had. So any other outstanding questions before we wrap up? And I'll just say, I think we have an upcoming provider forum that we're working on as well. I would anticipate us talking to you all again sooner than we did in this past time, as we hopefully get closer to being able to provide some subsequent information answers. And we will be looking to schedule another advisory council in the coming months. But do want to thank all of you for joining and for participating along the way. We appreciate any input, and if you'd like to share anything after this, we feel free to send us and send an email to myself, Ratmata. Any other questions before we break? All right, thank you all.
Thank you. Thank you.